Welcome to Dental XP. My name is Dr. Dean Vafiatis. I'm the Program Director at the Full Mouth Rehabilitation Center at NYU Dental College in New York City. Today we'll be talking about computerized dentistry, computerized abutments, and computerized crowns. We realize that today in function of our society, the computers are very accurate and they're working well in our implant and other restorative means. So we're very excited to work with them. Most patients come to us for certain types of technology. We have encode complete, we have performance posts, we have provisional restorations that we can use, we have CAD/CAM frames now that are being made. And the point of all this great technology is that it's practical, it's affordable for the dentist and for the patient, and we can now deliver restorations that have been fabricated with computers with much more accuracy, with much more predictability. And the exciting part is that all these technologies, once they are in place in your practice, they are affordable and they are predictable. So that makes implant dentistry a lot easier for most people. And also for me as an educator, it's a lot easier to teach a lot of the doctors and a lot of my colleagues. So I'm very excited to share some of the restorations and some of the treatment sequences that we've had over the last couple of years. We published a 2-year preliminary report in 2007 in PPAD, August of 2007. So this is a follow-up. This is a 5-year preliminary follow-up of a prospective study since that time of 143 restorations that were generated with a computer-generated implant abutment. And how that's done is with the Encode healing abutment from Biomed 3i. There's different types of papers that have been published, Osario and Kirstein and Duke, on computerized abutments. They use the Atlanta system, which is very successful. And we all found that the aesthetic appearance of the natural tissues, the chair time that was reduced, the laboratory time that was reduced, and really the shape of the abutment that was created from the Encode abutments was really something advantageous. Some more clinical reports of computerized abutments, but as you see, there's only 8 or 9 or 10 in the last couple of years. These references you can look at, and you can look at the case reports that were presented, and you'll realize the value of the computerized abutments. So this is a 4-year clinical report. Now we're up to the 5th year. 30 patients, 113 were done with the regular Encode system, and the last 30 have been done with the Encode Complete system, which means that the Encode Complete is where the actual analog is placed by the robot, and there's no need anymore for fixture-level impression. And that's the biggest advantage comparing it to the Atlantis abutment, whereas the Encode abutment does not need a fixture-level impression, and that's the biggest benefit. The factors that influence anatomical shape are usually the width of the implant, the depth of the tissue interproximally, the angulation of the placement, and the distance of the interocclusal arch. Those factors play a role in choosing the correct abutment. And in the past, where we were choosing the prefab abutments, many times after our restorations were made, the size of the abutment that was chosen and compared to the size of the tooth that was restored was a big difference, and there were some food impaction issues. So now we look at the Encode abutment, and what is it really? Well, it's a coated abutment that has facets on the outside of the healing abutment. You can see the healing abutment has come off the tissue about 2 to 3 millimeters, so the computer can read it and the impression can be made. The healing abutment has the information is transferred from the healed tissue, from the depth of the tissue, and also it transfers the information of the hex position of the implant. So all those factors are captured by those facets and those grooves on the healing abutment. To reiterate the point of the width, the depth of the healed tissue in a 360-degree fashion from the mesial, facial, distal, lingual, and the healed tissue, and also the angulation and the internal hex position. So all these pieces of information are captured by the Encode abutment. We use a 3-visit protocol, and really the first visit, impressions and intraocular records, is really a 15 to 20-minute visit. So we kind of call that a half of a visit. So it's really a 2.5 visit protocol. But as you see how the cases progress, you'll see how the treatments are more efficient in this way. The first restorative visit will take a final impression, single unit or multiple unit. The impression should be clear. An interocclusal record, vertical dimension, and maximum intercuspation or centric occlusion is made. The laboratory mounts the casts on a Stratus articulator, and it's calibrated, and we make sure that every impression is clear. The lab prescription, and this is important, so you may want to write this down. Please fabricate computerized generated abutment 1 millimeter below the tissue. That's what I recommend after doing this for 4 or 5 years. Some clinicians choose 0.5 millimeters below the tissue. Some clinicians choose 1.5. So that's your specific decision to be made at the time of your prescription. And usually what I teach as a general rule, the posterior should be about 1 millimeter, and the anterior should be about 1 millimeter 0.25. So I would say 1.25 on the anteriors and 0.75 to 1 millimeter below the tissue on the posteriors. We also ask for a provisional restoration from the laboratory, and we ask them to fabricate a PFM casting if it's going to be a PFM unit, or a zirconia coping if it's going to be a zirconia crown. So that's what the prescription should read. The design order is written by your laboratory. It's sent from your laboratory to a facility, CAD/CAM facility at Architect PSR at Biomed 3i in Florida. It returns to them the next day to the facility. It's mounted, and then it's put on a scanner where the optical light will scan it. And then the Encode abutment within the internal technicians at 3i, it's basically designed between 30 minutes to 1 hour. Each abutment can be designed and get ready for fabrication. So you can see the marginal design is different. You can see the XYZ factor of a three-dimensional view of the abutment. And basically we have a virtually abutment scanned, and the data will fabricate a perfectly aligned anatomical position for the abutment of that specific patient for that specific size of the tooth. Once that is done, the technician is happy with the position of it based on the parameters that the doctor has dictated. The margin placement is dictated by the doctor. The margin design is based on the tissue. It could be a chamfer, it could be a shoulder. The parallelism, of course, aligns perpendicular to the occlusal plane. The tissue extension is adjusted circumferentially. We know as the abutment goes through the tissue, on the lingual it may be 5 millimeters, on the facial it may be 2. So that's adjusted with the computer based on the original impression. And the emergence profile is just the way we like it, coming out of the tissue and creating a nice emergence profile. The analogs now with Encode Complete are placed with the robotic arm. So now the need for the fixture level impression, the need to take on and off healing abutments and place impression copings, that is now eliminated. And that, I think, is a big factor for the tissue in scalloping and causing some recession possibly, or having any kind of trauma to the tissues that may not be necessary. So the fixture level is not necessary anymore. And in one part of the facility, the Encode is fabricated from the milling machine. It takes about 15 to 20 minutes to mill it out. And in the other part of the facility, the analog is placed. So at the end of the facility, at the end of that assembly line, the abutment and the analog are placed together, and that's returned to your laboratory. When your laboratory gets it, they make a provisional that we've requested, and then they make the casting, or the PFM casting, or the zirconia coping, depending on what you've asked for. So we can see in this patient treatment, stage 1, we've taken the impression, phase 1, first visit. The second visit, we remove it. So we finally remove the healing abutments at the second visit. We conveniently place our abutments in the right position based on a jig, an internal jig that is made by the laboratory. And once that implants are placed, they're locked into position. The casting are tried in. We take a new vertical dimension bite. We take radiographs at that position of the abutments. We take radiographs of the castings, make sure there's no errors there. And then we take a pickup impression. This is a crucial part of the three-visit sequence. A pickup impression of the zirconia copings or the metal castings will negate all the errors that have been created up to that point. With that, now the technician can go right to ceramic restoration and go to porcelain, getting the contacts correct, getting the occlusal contacts correct. Then we will put the provisional in position, cement it in position, and on the third restorative visit, we'll go ahead and cement that delivery. Now, when we talk about cements, the least retrievable cements that we use for long abutments greater than 7 or 8 millimeters is the Tempon NE, the Tempon cement, or the Temrex cement. If we have medium to short type of implant abutments, we'll go to a Temrex or a Durolon with Vaseline, and those become very retentive. So the radiograph after cementation also is highly recommended to make sure that there's no cement-lined excess cement in the tissue areas. And we see here the 4-year post-op of one of our first patient treatments that we did 4 years ago, and we can see that the tissue and the aesthetics and the position have been maintained. And basically we're trying to avoid food impaction. So the anatomic abutment hopefully will create that emergence profile and avoid the food impaction. And when we deliver a single unit PFM crown delivered with Tempon, another topic we sort of discuss is the occlusal contacts. And if we look at a single unit molar that has been restored, well, they say let's make the contact in a light occlusion. Well, I always ask my colleagues, what is the definition of light occlusion? How do we measure that? And how do we know where our occlusion really is? So by looking at the occlusal markings, we can see that the posterior tooth has the most contact because it is the most posterior determinant of the mouth. And then we use paper, occlusal paper that's 9 microns, the artist foil, 20 microns, the red Accufilm, or 80 microns on the blue articulating paper. Now with that, we can sort of start gauging our light contact, and we will use our 20 micron paper to just slip through of the first molar implant restoration. And our artist foil, our 9 microns, is holding on the most posterior tooth. The question happens when we have posterior teeth, the most posterior tooth, when we restore it with the end code and we get our final restoration, well, where should the contact be at that point? And I feel that that posterior implant should have a good occlusal determinant, meaning that our mandibular position should not vary. I would not suggest having that last posterior tooth that's an implant out of occlusion or light occlusion, because usually patients complain that they can't really eat and they can't really chew and they can't really chew their food. So we will recommend having contact equal to the tooth in front, and the patient can have the equal contact. So that needs to be measured with each patient. With end code complete, we can go the first visit, impression, counter model, occlusal records. That gets sent to the laboratory. The second visit, it gets sent to the end code facility. On the second visit, it returns to the laboratory. The laboratory makes individual, in this case would be individual copings and PFM copings. Once the abutments are placed in the mouth, radiographs are taken. We go ahead and place the copings. We make sure that they fit in the proper position. Make sure they are down. X-ray radiograph is taken. A new impression is made at that point and a pickup impression. So the third visit, we can successfully deliver 8 units of implant restorations in a 3-visit protocol with good occlusal contact, good anatomy, and really a predictable, streamlined approach to implant dentistry. And that's really where the value is. Their option is to come into a titanium nitride option where the color and the hue of the abutment is a gold hue to have a better translucency through the tissue. And that's, again, optional. I would probably recommend that more in the anterior region than in the posterior region. Some of the results, the implants that we restored with this method, 113 happened to be individual units, so 79% of them are individual units. Now the tissue response to all but 6 restorations was excellent. Well, what happened? What we realized in the first 20 or so restorations, when we placed the abutment in position, the tissue happened to roll over. Another problem was we were not asking the laboratory to make the abutment at 1 millimeter below the tissue. We were asking them to make it at the tissue. That conversely led to when we placed the abutment, the tissue would roll over and we started getting the recession in the black line. Once we realized we had to specifically say 1 millimeter below the tissue, as the tissue was pushed, there was enough compensation that we stopped getting that line, and that since that time we haven't had that problem. So all of our restorations at this point are requested at 1 millimeter below the tissue. So of those 6 abutments, so we had that problem, we had to re-prepare and make new abutments and make new crowns for those restorations. We also realized that 4 of those had surgical augmented grafts, which also could have possibly caused that restoration to be a factor. New abutments were fabricated at a lower Carlin margin, and that accounted for 3% of the abutments that had to be changed. And it was within the first 20 restorations that we had recreated. We noticed that radiographically there was no micro gap. and it was virtually invisible to see it, so that was a good thing. You had a machine product with another machine product, and you really couldn't see the microgap. None of the other implant restorations exhibited recession, inflammation, or any unfavorable result, but one of the 143 restoration, all of them but one is in function. It failed 7 months after restoration. It was a premolar, first premolar. We don't know why it failed, but it has been recently replaced with a new implant restoration. The value of Encode, as I see it, is not only for single and multiple units now when we get to full arches. When we have patients with full arches, we can see that abutments can be tried in a lot easier. And in this patient treatment, we see the final impression of the Encode has been made. You could imagine that taking off 12 healing abutments and placing 12 impression copings would be a very time necessary procedure, which would be really difficult for most clinicians. So by this technique, we can take a final impression, no fixture level impression. It's designed by the laboratory. The abutments are returned to us and to the laboratory, and then the laboratory is going to make the individual castings. In this case, we had a 3-unit bridge from tooth number 6 to number 8. So there was one solder connection between 6, 7, and 8. So we face bow and we do a pickup impression at this visit. We get a Bisbake trine on the 7th visit, and on the 8th visit we can deliver full arch restoration. So with the Encode abutment, the abutment process is a lot easier. The impression process is a lot simpler, and it saves a lot of time for everyone, the clinician, the patient, and the laboratory. We recommended canine protected occlusion in full maxillary and mandibular implant patients. And the Encode Complete now has served over our 39 to 45 patients in a very successful manner, and that's Encode Complete. Part of the post-op instructions, I wanted to sort of cover that. Radiographs at the insertion, the natural dentist rinse, we use that product instead of chlorhexidine. Occlusal contacts are checked at the insertion visit. Food impaction is checked in 3-week post-operatively. 6 months later, we check for cement leakage or decementation. And in 1 year, we recall the patients for screw loosening. We check that. Now, with the internal certain connection, we haven't seen any screw loosening in the last 4 years. But we definitely have seen some occlusal contact changes, so it's something to be wary of. All the restorations are cemented with retrievable cements. Patient tear time was drastically reduced. That's one of the observations we saw. We saw it was also important to, when we did the cementation, make sure there was no cementation below the gum line. The advantages are, again, no fixture level impression. The laboratory costs are more predictable. We don't have to use custom gold abutments anymore because of that cost was a very variable cost. There's no capital investment for the laboratory. That's a big advantage. And of course, the chair time was minimized. These definitely cost more than prefab abutments, but the value of the time that's saved, I think, can outweigh the cost of the prefab. And also, it's contraindicated for screw retain restorations. So things you need to know to use Encode abutments: abutment placed at the time of stage 1 or stage 2. The laboratory is ready with all the Encode documents, a clear impression, clean cast mounted on the stratus articulator, and a FedEx account. I want to thank the surgeons, the periodontists, and the laboratory technicians for their extraordinary work in creating this presentation, and the people at Architect PSR who've really also helped me with a lot of the designs. So I thank you for your time, and this was presented at the Academy of American Implant Dentistry. And again, I thank you for your time, and I hope you enjoy this presentation from Dental XP. Thank you.